According to research at Cambridge University, it doesn't matter what order the letters in a word are. The only important thing is that the first and last letter be at the right place. The rest can be a total mess, and you can still read it without a problem. This is because the human mind does not read every letter by itself, but the word as a whole. What if I told you you read the top line wrong? As a result, the patient died.
We work in a high-risk industry. You'd be extremely upset. Some staff commit suicide after events like this. You may be reprimanded. What else? Information about what happened would be passed up the chain of command to those far removed from the event, and they'd have meetings. There may be a root cause analysis. We may create a policy or guideline or mandatory training program, or send out an alert to remind staff to read the sign properly. We may do all of the above, and we'd expend a lot of energy and money in doing so, and we will have wasted our time, because another doctor or nurse will come along and read the sign incorrectly, and another patient will die. Because what we should have done was change the sign. Imagine for a moment training students to be the best they could possibly be at passing an exam. Then every day making the exam just a little bit harder. Over time we might expect to see an increasing failure rate like this, except this is actually the adverse event rate in the NHS. Every day our workplace is increasing complexity with new drugs, new equipment, and a constantly renewing workforce. The greater the complexity, the greater the risk of error. If the interventions we put in place to deal with these errors only further add to the complexity, more policies, more alerts, more forms to fill in, then we design our hospitals to increasingly fail. We're going in the wrong direction. We need to change the sign. The British Medical Journal published this 2 years ago, Medical Error, the third greatest cause of death, claiming doctors and nurses accidentally kill more patients than motor vehicle accidents, strokes, diabetes, and suicide. In my 25 years of healthcare, I've yet to meet a single doctor, nurse, anyone in healthcare who doesn't want the best for every patient. So surely this can't be true. One way we look at this data is to deny it, isn't it? We say most of these patients are sick and they're going to die anyway. When you truly understand safety, you'll realize, yes, they will die anyway, but not because they're sick. It's because the healthcare system is sick. Safety experts have a mantra. Every system is perfectly designed to get the results it consistently achieves. Healthcare is perfectly designed for medical error to be reported as the third greatest cause of death. Wouldn't it be amazing if we could cure the healthcare system and save those lives? We need to change the sign. Ergonomics, also known as human factors, is about designing the workplace and the equipment in it to accommodate for limitations in human performance. It's about changing the sign. This is the hierarchy of intervention effectiveness, a simple diagram showing how human factors experts see safety. They understand how we interact and that we all make mistakes. We can't change this human condition, however we can change the conditions humans work within. The people-focused interventions we've relied on in healthcare, warnings, alerts, policies, human factors experts consider less effective. Greater emphasis is placed on the systems and equipment we interface with. Are there thousands of lives to be saved simply through changing the sign, through respecting and designing for our human limitation and listening to those not conditioned to do things the way we've always done them?
After heart disease and strokes, medical error has been reported as the third biggest cause of death globally. The exact figure is difficult to estimate because error reporting in healthcare lacks transparency. But mistakes made in hospitals are leaving patients worse than when they went in. A group of medical staff decided enough was enough and began to agitate for change. Communication errors have been identified as the root cause of the majority of mistakes. Staff in operating theatres can work with hundreds of different colleagues between multiple hospitals, and their faces are covered, so in the midst of an emergency, precious seconds can be lost when clinicians don't know or can't remember the names of their colleagues, which can lead to lack of accountability, wrong equipment used, wrong drugs administered, and so on. To improve communication and reduce mistakes, the answer was remarkably simple. To immediately identify individuals and their roles, we began writing our names and roles on our scrub caps. It was a simple act which changed the culture of the theatre from anonymous to collaborative. Suddenly, it was easier to coordinate, to be more accountable and efficient. With the help of a hashtag, the idea began to take off. Medical staff globally joined in. Some even started printing their own name caps. The world sat up and took notice. What started as a simple idea among a bunch of so-called rabble-rousers has grown into a game-changing movement which is saving lives around the world.
Surgeons only know 44% of staff names in their operating theatre. Not surprising when we realise, as humans, we're very poor at remembering names. Wearing name and role caps increases staff name recall to 85%. It helps overcome our human limitation. Use of first names is the single most important non-technical skill. It improves communication, increases the propensity for staff to speak up, reduces confusion in theatre, improves morale, teamwork, and ultimately it improves patient outcomes. How else can we design to accommodate for our human limitation? In this study amongst anaesthetists of over 180,000 patients, of those intubations that were difficult, 93% were unpredicted. Like it or not, as anaesthetists, we're very poor at predicting difficult intubation. Further, the greater the number of times we attempt laryngoscopy, the greater the adversity. Adverse events like desaturation, esophageal intubation, and aspiration. Increasing adversity with increased attempts was also demonstrated in NAP4. NAP4 draws on data from all NHS hospitals over 1 year, an estimated 2.9 million general anaesthetics. Severe adverse events included death, brain damage, emergency surgical airway, and unanticipated ICU admission. Many events considered avoidable. One would think, given our human limitation, our impaired ability to predict airway difficulty would gift ourselves and our patients with the best chance of successful laryngoscopy, first time, every time. Interestingly, Dr. Tim Cook, who presented the NAP4 data, and the staff at his hospital seem to be doing just that. This is now the norm within his hospital, and they've published this in the BGA. There are many other hospitals around the world now doing this. Within my own main hospital, we've had Macintosh video laryngoscopes in every theatre for the past 4 years. This stance is well backed by the evidence too. I've been performing laryngoscopy for more than 20 years, well before video laryngoscopes hit the market. I consider myself skilled at direct laryngoscopy, yet even those skilled at direct laryngoscopy have higher success rates when a Macintosh video laryngoscope is used. This makes complete sense. Mac VLs provide both direct and video views. This is always going to be at least as good, and often better, than a direct view alone. It's important we realise not all video laryngoscopes are the same, those designed to provide video and direct views superior to those allowing video views alone. Again, this is backed by the data. This simulated difficult airways trial indicated success rates of 98% with the McGrath Mac, greater than those designed for video views alone. One would think we'd use the best device in the interest of our patients first time, every time. But are we? And if not, why? One reason often given is that staff may become de-skilled, unable to use direct laryngoscopes if they train with devices allowing video views. A recent study of over 14,000 intubations appears to refute that argument. So what do we do, and why? Which brings me to the laryngoscopy survey. This went out on social media with this picture and request. The question breakdown quite simple, and depending on the answer to your first question, you are asked a different stem for the second question. My main interest was to find out amongst those who use a direct laryngoscope first time, if their choice would be different, given immediate access to video direct or video laryngoscopes, the excuse of cost or availability could no longer apply. This is the unfiltered results for the first question, the vast majority of responders using direct laryngoscopes first line, perhaps an issue of restricted access to the better device. Unfortunately not. Do we do things because that's the way we've always done them, at the expense of optimal patient care? Healthcare management utilizes top-down structures. These structures are extremely efficient when used in simple environments. They harness loyalty and professionalism and maintain conformity and accountability. Yet they resist change, particularly ergonomic initiatives. Healthcare is an extremely emotive profession. Patients die at our hands. To suggest, particularly to our superiors, that we should do something differently can be highly offensive. Do we become conditioned and develop siloed beliefs that perpetuate throughout our specialties and industry? One would hope that as time passes, these siloed beliefs quickly disappear as new staff come into a specialty, people more willing to accept a different, better way of doing things. This is what I believed, until the results came back. Irrespective of being new to the game, anaesthetists were more likely to choose direct laryngoscopy first line. Also, they seem just as likely to stick with their decision of direct laryngoscopy when other devices are available. Same with intensivists. A slight difference amongst emergency physicians, yet the only group who really appeared willing to do the right thing, to do the best for patients, first line, when given the choice, were paramedics, particularly those new to the game. What strikes me is that paramedics have had a different career path. Are they more aware and accepting of their human limitation? And does this lend them to do the right thing? So what is it that will lead us as doctors to do the right thing, make us change, realign us and drive us to, first and foremost, do the best for patient care? It doesn't appear to be evidence or cost. Perhaps it's something else. Allow me to digress. Anaesthetist Dr. Jen Dixon tweeted this just over a year ago, confusion about a time-critical number. Standardizing the internal hospital emergency number provided a great opportunity to demonstrate how effective a networked approach can be in delivering change and improvement. We crowdsourced the data, finding at least 51 different numbers across Australia, and discovered elsewhere in the world others were trying to do the same. The UK standardized at 2222 10 years ago, and there's a push to standardize throughout Europe and internationally. Dr. David Whitaker, the main driver behind this. So we introduced him to our Basecamp group, a great project software platform allowing documents to be stored. Anyone in the group can pitch in at any time. We might, for example, work together on a message to send out further. This infographic sent out on social media. As well as social media, we've great links with mainstream media too. We hit the front page of the Sydney Morning Herald, and all the time we continue to develop strong connections with healthcare governance. And within a year we'd managed to achieve something which took the NHS twice the time and cost them millions. All this from a single tweet. Ripples of change become waves of improvement. We'd like to drive this change internationally and believe we can. But what is it that makes a hospital introduce change? Perhaps something social psychologist Malcolm Gladwell illustrates through this man. This is NBA star Wilt Chamberlain. In 1962, he scored 100 points himself in a single game of basketball, a feat that's never been equaled. What's fascinating, though, is Wilt made 28 points from the free throw line, another unbeaten record. Fascinating because Wilt was useless at free throws. However, the season before, he was persuaded to change his style and throw the ball from between his knees like this. His success rate took off. What intrigued Gladwell most was the following season Wilt reverted to the regular overhand technique. His success rate plummeted, yet despite this, he persisted with the overhand technique for the rest of his career and never had a high score again. In his autobiography, Wilt Chamberlain regrets reverting back, however felt he had to, because in his own words, he didn't want to be seen as a sissy. He put his own reputation first, and in doing so, let his team down. a trait which can be common to us all. Question is, would you let your reputation get in the way of doing the right thing? Or better still, can we create a system which aligns our reputation with doing the right thing, which aligns our reputation with providing the best in patient care? Well, yes, we can, and we have, and it's been used with great success in driving emergency number standardisation, displaying those hospitals which have standardised in green, those for which we've the details but haven't standardised in amber, and those for which we haven't received the details in red. Scoring in this way encourages transparency, a better score where the information is available. Where required, we can apply this technique to any project. Does your hospital support staff wearing their name and role? Does your hospital provide video direct laryngoscopes in every theatre? Just as domestic equipment has been rated for years, collaboratively we're able to rate the healthcare equipment and systems we interface with. Institutions given an aggregated score based on the system is in place. These scores give impetus for hospitals to improve and move up a league table. This is the Learning from Mistakes League, a subjective table based on frontline feedback. Working together, we're making this objective, driving safety improvements throughout healthcare. Working together, we'll change this and start heading in the right direction. And working together, we'll create the best environment for patient care. Thank you.